want to thank the organizers for inviting me to come speak. So I'm going to talk about Richter's syndrome. We've heard a lot about it already throughout the day, but I'll kind of impress upon you some other topics that we haven't spoken about yet. We'll talk about the risk factors for transformation. We'll look at predictors to treatment when patients are actually treated for Richter's, and then outcome. So for the agenda today, we'll talk about a little quickly the background, epidemiology, some of the clinical biological risk factors, and then we'll compare some of these paired samples that have helped our understanding know what are the acquisition events in terms of transformation. We'll compare a Richter's DLBCL to de novo DLBCL, and then look at the clinical predictors to outcome, impact of transplantation, and Richter's syndrome in the era of novel agents, and then talk about a few of the new directions we're going. So quick background, you can't get out of coming here into New York City without knowing a little historical fact, but Dr. Richter was a good citizen of this fine city and was a professor of pathology at Columbia as well as chairman of pathology at NYU. But essentially, his seminal paper was in 1928 where he had a patient who had CLL and had a rapid decompensation and died secondary to this disease. And on autopsy, he was able to see that these large admixed cells, these sheets of large atypical cells admixed with smaller CLL-like cells, and this is a liver biopsy. And it was the first time that anyone postulated that possibly these cells arose from the previous cell that was diagnosed in the patient years prior. So just some statistics on the disease. Really I want to press upon you as well is that the term Richter's syndrome or Richter's transformation really should be restricted to patients who have CLL who then transform. We now know that there are stark differences between a follicular transformation versus a Richter's transformation. 90% of these are DLBCL. We'll find that the majority, 90-95%, are ABC subtype or non-germinal center as the cell of origin in comparison to a follicular transformation, which is typically germinal center. And when you look at the clonal relationship, close to 60, closer to 80% in most studies show that the Richter's transformation is actually clonally related to the underlying CLL with similar gene mutation, IgHV mutational status, as well as molecular genomic data. Also important to note that 80% of these Richter transformations actually are lacking any association with EBV. And when we do see a potential EBV-related DLBCL in the setting of CLL, we might want to start to think that this may be more of like a PTLD and not necessarily clonally related. When you look at the remaining 10% and you start to get into rarer variants of this already relatively rare disease, but the remaining about 10% are majority of Hodgkin variant Richter syndromes, which typically outcomes are worse than a de novo Hodgkin lymphoma, but are definitely better than those outcomes that we see in Richter's transformations, with median survivals of Hodgkin variants of about 3.9 years. And ABVD remains kind of the standard of care, and there's very limited data in terms of brentuximab vedotin and other newer agents that we're using in Hodgkin's and how that could potentially impact these patients. And when you look at the risk, the 10-year risk of a Hodgkin variant Richter syndrome in patients with CLL, it really approaches about 0.5 to 1% of all patients will develop this at about 10 years, whereas in CLL or in DLBCL subtypes, we'll see at the next slide, is much higher than that. And then with the Hodgkin variants, there's a frequent association with EBV positivity, much like the de novo Hodgkin's. And then there are even rare subtypes but when I'm talking going forward, I'm going to be specifically focusing on DLBCL, Richter's transformation. So you'll hear a lot about the annual incidence. You'll hear a lot of different numbers quoted to you about what the true incidence rate is. Anywhere from 5 to 20% of patients with CLL can get Richter's in terms of the literature. When you look at the cohort studies and the ones that have published these numbers, there are a few problems with them. Some of the studies had more aggressive biopsy procedures. Some studies took all patients as a referral center. And so when I like to quote the incidence rate, I really like to use what was recently published by the Mayo Group, where they looked at, why it's better is that they took 1,600 patients and restricted it to those who were diagnosed with CLL within the first year of coming to their center, and these were all then patients that were subsequently followed. And what you see is that the incidence rate really approaches about 2.5% at about 4 years, and then at 10 years out, it approaches about 5%. This is all patients. This is high and low risk patients. But then when you see treatment starting to add treatment into these patients, you do see the rate of Richter's transformation increase over time from the time of first therapy. And in this situation, it was mainly with fludarabine-based and chemotherapy, cytotoxic chemotherapy regimens. But that you can see that close to 10 years, we're seeing about a 15% of patients once they are finally treated, which also selects for a higher risk subset. The clinical and biological risk factors for transformation are, you'll see a lot of different studies out there. Really, when we look at clinical risk factors, there's not many things that we normally typically look for, or see that help differentiate patients at diagnosis that are going to require treatment, like we do in CLL with lymphocyte doubling time, beta-2 microglobulin, certain laboratory abnormalities. What we do see, though, is if patients are presenting with big, bulky lymphadenopathy, David Rossi has shown in the Italian group that he works with, shown that bulky lymphadenopathy greater than 3 centimeters is an absolute risk factor. Others have shown it's 5 centimeters, but regardless, it's true. Bulky lymphadenopathy is the major clinical risk factor that has come out repeatedly that shows a patient to be higher risk. Interestingly, they find, and this has also been repeated, that deletion 13q patients actually have the lowest risk of transformation. There's some theories about the genes that are there that are implicated in transformation. We'll talk about that later. When you look at other biological factors, a lot of the things that we see as aggressive CLL also hold true for patients at risk for transformation later on. You'll see, and these are all corrected for rise stage to try to correct for advanced stage high-risk patients. But you see, again, IgVH mutational status, ZAP70 status, CD49, CD38, as well as obviously the FISH categories with 17p deleted patients having the highest risk. Again, David Rossi has also shown telomere length at baseline at diagnosis also predicts Richter's transformation, and in those patients that have short telomeres at diagnosis are the patients with the highest risk. You see approaching close to 20% about 6 or 7 years out. Another important biological risk factor and molecular risk factor that we find is very important in terms of assessing a risk towards transformation is our immunoglobulin stereotype B-cell receptors. And we find that those patients, so about 30% of CLL patients exhibit a stereotype B-cell receptor, and a stereotype B-cell receptor essentially is a VDJ combination that is more commonly seen in CLL than would be expected at just random chance. And you see here that if you have a stereotype B-cell receptor, your chance for Richter's, again, at 6 or 7 years is approaching 20% versus those who do not. When you start to look at mutational status of the V gene and then incorporate whether or not it's on a stereotype B-cell receptor or immunoglobulin chain, you then again can stratify patients. And again, those with unmutated V genes along with stereotype CDR3 regions also have this high risk of transformation at about 6 or 7 years, approaching this 20%. And when you start to look at specific high risk V gene usage, we also find patients with stereotype B-cell receptors and certain V gene usage such as 4-39 or subset number 8, which is this group, have extremely high rates of Richter's transformation, again approaching 80 to 100% at 5 years. Interestingly, when we look at other high-risk stereotyped B-cell receptor or immunoglobulin genes that we use, such as V3-21, we don't see quite as high of a risk. So there does appear to be something related to V-39 usage. As a caveat, the paper from the Mayo group, when they looked at their 1,600 patient cohort and about 37 patients had transformed, they actually did not find any V4-39 patients in that cohort. So it's still, there's still a lot of evidence that it does appear to predict, but the jury may be still a little out. When you start to look at molecular defects, Notch1 mutations really have been the major predictor for Richter syndrome risks and transformation. We've seen these slides earlier today, but again, if you have Notch mutated, your risk over 10 years is again approaching 20 to 35%. And then when you start to combine these mutations, again, with the V gene usage of high-risk immunoglobulin, such as V-439, again, you see a very high chance of risk. So while this is a very rare subset of patient that we may come across in practice, we should be thinking, to keep a very close eye on these patients because over time that their risk seems very high for transformation. And this may occur prior to treatment. So when you look at comparing Richter syndrome to the precedent CLL, our knowledge has really greatly increased over the past couple of years by a few of these very seminal articles that were looking at basically the first time of large pairs of CLL phase compared to transformation in lymph node biopsies. And Fabry et al. Was able to show with whole exome sequencing as well as copy number alteration analysis, several cytogenetic chromosomal abnormalities that seem to be acquired at the time of Richter's transformation. The most common in recurrence are here, as you see, at 9p21.3, which houses CDK N2B and A, which is a tumor suppressor. So we typically lose that, and this is an acquisition event in about 30% of patients. Subsequently, we see P50 or 17p deletions occurring at acquisition, so it wasn't there at baseline when patients have transformed after a few years of therapy, or whatever it is. We find that in their Richter's lymph nodes, we're finding P53 deletions. And as I said before, 13q deletions are actually not very common in Richter's syndrome, and it seems to be a protective effect. But when we do see it, and you do see that there's close to 20% do have a 13q that transform, but when we do see it, we also see P53 alterations, we see Notch mutations, we see other MYC activating alterations in combination with the deletion 13q. When you look at gains of chromosomal abnormalities, really the most common ones and the most significant are obviously at 8q with MYC being important there, as well as trisomy 12. Trisomy 12 patients do have a higher risk than other patients of Richter's transformation, though overall their CLL seems to follow a rather intermediate course. But trisomy 12 is also one of these very highly recurrent in about 30% or so of patients at time of transformation. And so the reasons for that aren't necessarily clear. It's also interesting that in this paper they saw that trisomy 12 alterations were somewhat mutually exclusive of the other ones that we're seeing. And so when you look at moving on to just mutational status of the genes that they examined, we find that a lot of these mutations are in tumor suppressors rather than in oncogenes and true activation. You can see in green are the tumor suppressor genes, and you can see many more are altered than true oncogenic effects. And then similarly, these two papers kind of came out very close to each other in 2013, and similarly we found epigenetic differences between the precedent CLL and at time of transformation. And I just want to highlight here again, CDK2NA, N2A is also one of the most hypermethylated regions, so you might expect that hypermethylation of this region is going to be a very similar effect as a loss of that chromosomal region. And so there are absolute clear differences between the epigenetics and the genomes and then the chromosomal abnormalities seen in Richter syndrome compared to that preceding CLL. Moving on, when you look at comparison to de novo DLBCL, we also see very stark differences in terms of mutational profiles, chromosomal abnormalities, and epigenetics. Importantly, in ABC subtypes, and now these Richters were all clonally related. In the initial study that did the paired studies, there was about 12 or so. So these 12 clonally related were also included with a subsequent subset of outside Richter syndrome samples. And what we find when you compare to ABC subtypes, we do not see PRDM1 mutations. We do not see some of the other highly recurrent mutations normally seen in ABC. We see them at much less frequencies in our Richter syndrome. And what we do find that in Richter syndrome, we see an increase in P53 mutations, which are relatively rare in ABC, as well as a high prevalence of Notch1 mutation and Notch1 gain, these gains of Notch1 mutations. When you look at copy number alterations and translocations, they typically lack BCL2 translocations. They lack beta-2 microglobulin deletions and abnormalities there. And when you look at biallelic disruption, we see A20 being very commonly abnormal in our ABC phenotype and PRDM1 again. And then when you look at P53 biallelic disruption, it's more common in our Richter syndrome. And the same story, again, is with our GCB subtype. I told you these are all typically ABC subtypes, and so it's not surprising there's going to be big differences here. But in terms of comparing it to like a follicular transformation, we see lack of CREB-BP, lack of EZH2, which are somewhat common in the follicular transformations, and again, Notch, and then P53. So very recurrent themes and very stark differences in terms of the mutational profiling. Again, the epigenetics that are seen between de novo DLBCL, again, just demonstrates that this is a distinct biological entity different from DLBCL. You see our DLBCL here on the right, your left side, and then you'll look at our Richter syndrome, which is in purple, clusters very closely to CLL, and in fact, the patients with paired Richter syndrome CLL samples cluster very closely together. So they are much more similar than they are different and much different than DLBCL. So moving on, when you're looking at predictors of outcome to therapy, really we want to know what the clonality of the disease is. David Rossi has shown, and as others, that the clonality, if you are clonally related, your outcome is much worse. The disease is a little bit more refractory versus those that are clonally unrelated. They follow a course much similar to a de novo DLBCL, respond very well to CHOP-like regimens, whereas those that are clonally related do not. MD Anderson in 2006 published the first kind of understanding of how to assess our risk factor of when you get diagnosed with Richter syndrome. And in multivariate analysis, these 5 predictors came out, and they developed the Richter score with that. So when you see a patient at diagnosis, you can give them this score. It helps prognosticate of the course that patient may have, and it can very finely break patients up and stratify into low, intermediate, and high-risk groups for poor outcomes. And again, when you start to incorporate mutational profiling and abnormal genetics, David Rossi has again shown that if you have P53 disruption, whether it's deletion or mutations, you can also stratify patients into poor outcomes and higher and better outcomes. So the chemoimmunotherapy regimens, there's no real standard first-line therapy for Richter syndrome. We still believe that CHOP-like regimens are kind of the standard first line, and most patients will get those. And you can see a lot of other regimens, hyper-CVAD, OFAR, some of these other regimens that have been developed, especially for aggressive leukemias, lymphomas, and specifically for Richter's. I just want to impress upon you that chemotherapy is not the whole answer here. And in fact, the CR rates and the overall response rates are pretty dismal comparatively to your de novo DLBCL. And subsequently, the median survivals are even worse. We're looking at 27 months, 10 months, 8 months, and the median survival in most of these studies is anywhere from 9 to about 12 to 15 months. So when you look at the impact of stem cell transplantation, it's important to note that only about 10 to 15% of patients are well enough to get to stem cell transplant. And similarly, the MD Anderson group in 2006 showed the impact of a transplant if a patient can get there into a CR or PR, that your outcomes are much better than if you go into it as a refractory salvage therapy. And they also showed the few patients that got an auto, allo was also seemingly better in that group. The European group for bone marrow transplant recently updated some of their data on 55 patients that were transplanted with Richter's syndrome, and they found essentially relatively decent outcomes. Actually, they found better outcomes in patients that got auto-transplanted than those in allo, but you have to take that with a grain of salt because 80% of patients that got an auto had actual response. 35% of them went in with a CR, rather than only one patient went in with a CR, and the majority went in with either partial response or refractory disease. But you can see that the survivals after this are push it out to about 2 years, so after transplant, and then you're looking at about 3 years with auto. It's important to note also that when patients relapsed in the auto group, about 7 out of 11 of those relapses were with Richter's syndrome. The MD Anderson group also updated their outcomes after failure of allotransplant for CLL patients as well as Richter's transformations. And I'll highlight just the Richter's transformation patients, but you can see after failing an allo transplant, all of these patients went in with a partial response or progressive disease or refractory disease, and you can see after failing your transplant, you're pushing it about a little under 2 years. Importantly, and this has also been seen in other studies, that if you have GVH, your outcomes are seemingly a little bit better, to suggest that there is an immunocomponent here, immunotherapeutic component, and a graft versus lymphoma effect. And you can see here that allotransplantation was in fact able to get some responses in these patients. I said none of them went in with a CR, but we do see 40% or so of patients getting into a CR with the allotransplant. So moving on in the era of of our new TKIs and ibrutinib, we find now that we've asked this question of whether the effect of ibrutinib has on Richter's syndrome, and Cami Maddox and the Ohio State group has recently published, and we've seen these figures already, that it seems that this Richter's transformation seems to occur pretty early after treatment with ibrutinib, within the first 12 months to 18 months, first year and a half, and this does start to plateau. So about 7% of patients have transformed. And then if you get past that year and a half time point, it's going to be mainly progression of your CLL rather than transformation. Again, if you transform on ibrutinib, outcomes are very poor, and you're looking at median outcomes of about 6 months after that. Interestingly, of these patients, of the 18 patients that had transformation, 14 of them had DLBCL. 2 of those patients had a Richter's prior to getting on to these ibrutinib clinical trials. So of the 12 patients studied, 2 that had de novo Richter's transformation, 2 of them were found to have a BTK mutation in the peripheral blood. But it has not necessarily been documented that the BTK mutation is there in the lymph node as well. And then just an update on this paper by Faruqi has shown in a 17p deleted upfront treatment with ibrutinib that the transformation risk is still there. About 5% of patients who progressed with Richter's transformation of the treatment-naive cohorts, and also did it relatively early, within a year or so. I think one was at 2 months, and then one was around 15 months or so. 15 months. And so what are the new directions that we need? So obviously we need to start to capitalize on what we know and the differences between CLL and Richter's syndrome, as well as those differences between Richter's syndrome and de novo DLBCL. There aren't very many, if you look on clinicaltrials.gov, not very many targeted or not very many trials specifically for Richter's syndrome, but there are a few. One that is open and it seems to be somewhat effective is using selinexor or KPT-330. It's an XPO1 inhibitor. It's a nuclear export protein that can shuttle tumor suppressors, can also shuttle messenger RNA outside of the nucleus for transcription of oncogenes, as well as by inhibiting the export, you can keep the tumor suppressors within the nucleus to where they can then function and work. Obviously, these are still in early, very few patients have been enrolled on some of these studies, and so we don't quite know the clinical activity yet, but we have anecdotal evidence that it does work. PNT2258 is a BCL2 inhibitor. Also, which targets this, and Richter's does have overexpression of some BCL2, but not necessarily more so than in CLL or de novo. When you look at some epigenetic targets, we have a trial open with CC486 and oral azacitidine in combination with R-CHOP, which allows and enrolls transformed patients. And then there are arms with ACP-196 as well as ACP-196 plus pembrolizumab and immunotherapies that allow transformed patients, as well as CAR T cells, obviously with early phase allowing transformed patients as well. So in summary, I hope I was able to convey that Richter syndrome is an absolute distinct biological entity from de novo DLBCL and transformed lymphomas. Transformation is associated with specific recurrent mutational chromosomal and promoter methylation changes compared to paired CLL samples. These clinical, biological, and genomic information is now established for Richter syndrome risk factors as well as predictors for outcome. Current chemoimmunotherapy paradigms are relatively ineffective, and we need to find better combinations. Transplantation can improve outcomes, however, few patients, only 10 to 15%, are eligible. And even though there are currently only a few targeted approaches available specifically for Richter syndrome, we have seen responses, and they are starting to prove effective in achieving responses in these refractory patients. Okay, thank you.